Okay, good afternoon, everybody, and welcome to the Child Health Priorities Association webinar series. We have reached over 30 attendees, so we'll get going this afternoon. So I'm Denise Evans, and I'm also joined by my co-chair this afternoon, Zipo, and we are from HERO. And before we get going, I'd like to introduce the chair of the Child Health Priorities Association, Prof. Uta Voigt, who's going to give us a quick introduction. Uta, over to you.
Yes, thank you very much, and thank you for the introduction. Welcome to all of you. We are very happy to have you online. Obviously, it would have been nice to have an in-person meeting, but at least in this way we can meet, even if we're all over the country. So we're going to talk today, obviously, as advertised, on the ward-based outreach teams, and we're really looking forward to that. I really have a very short role to play today. I wanted to tell you about the Child Health Priorities Association. This is the list of current EXCO members, but this association is really all about its members. It's not about the EXCO. It is really for us to interact. We're a multidisciplinary group of people who are interested in, or who are committed to improve the outcomes in terms of child health in our country. And we welcome you to be part of what's happening in this association. Please make contact with us. You can contact us over our website, or you can send a note to any of us. We have a mailing list, so if you're not on the mailing list yet, then please let us know. And we also have a LinkedIn page and a Twitter handle. So please just let us do this together. We are also currently planning our next conference. You would know that we've had yearly conferences in terms of the Child Health Priorities Association. This year, we will be having a virtual conference. At our last conference last year, which was in person after COVID again, the decision had been taken that for now, we will alternate in-person and virtual conferences. So this is for the diaries, 5 and 6 December. We will be tackling the issue around the halfway mark of the Sustainable Development Goals. So are we on track to meet especially the SDG 3 goals, maternal and child health, and obviously focusing a lot on child health. And please send in your abstracts. You can see there, closing dates for abstracts is the 3rd of November. And the registration is live on our website. So you can from today onwards, you're very welcome to register for the conference. And please join us. As I said, this is planned in a way that you can still get some other work done as well. So we have 2 sessions, one in the morning, one in the afternoon for 2 days. And then again for the diaries, the next webinar will be on 26 October. And this is about looking at streamlining school referrals for learning challenges. So how do we effectively collaborate with the Department of Education, especially for those children with learning disability? And that is all from my side. Enjoy the webinar. Back to you, Denise.
Thank you. So just 2 housekeeping notices. So one, please just note that the webinar is being recorded, and we will place the recordings on this on the Child Health Priorities Association website. And then also please remember to put any questions and comments that you have for our speakers today in the chat, and then we'll address those at the end of the session. And so with that, I'd like to introduce our 2 speakers today. So our first speaker is Prof. Lena Thomas. She is a medical doctor working as a principal specialist in public health medicine in the Ekurhuleni Health District. She is also employed by the Gauteng Department of Health. She's an adjunct professor in public health medicine at the University of Pretoria, as well as a senior lecturer with the Department of Community Medicine at the University of the Witwatersrand. She has almost 30 years of working experience in public health sector in South Africa, and she has worked both at the hospital, district, and provincial levels. And then our second speaker, so I'll introduce both now so that we can just run the presentations back to back. Our second speaker is Professor Tanya Doherty, a specialist scientist in the Health Systems Research Unit at the SAMRC. Her research focus is health system requirements for the optimal delivery of priority child health programs at community and primary care. She has conducted several several cluster randomized trials and program evaluations of community and primary services in South Africa and across the continent. And she has published over 100 peer-reviewed articles. She is an honorary professor in the Department of Pediatrics and Child Health at UCT and the School of Public Health at UWC, and she teaches and assists with student supervision. And so with that, I'd like to hand over to our speakers. So Prof. Thomas, would you go ahead, please?
Thank you very much, Denise. Let me see if I can just quickly share my screen. I hope you can see my screen.
Yes.
Put it on slideshow. There you go. Yes, so good afternoon, everyone, and thank you so much for having me here. I'm a public health physician, and this topic that I'll be talking about is actually based on my PhD study that was done through the University of Pretoria. And I know that this isn't a research conference, so I'm not going to spend a lot of time on the methodology and so on. But I think that it's very important for each of us to really consider the potential of community health workers and how they could actually contribute to helping us achieve some of our health priorities in the country. And it's within that context that I'll be sharing the findings from my particular study. So just to set the scene, I think, even though South Africa is an upper middle income country, we know that it's highly unequal, and we have a huge burden of disease, the quadruple burden of disease, with poor performance in terms of mother and child health issues, as well as HIV and AIDS, non-communicable diseases, violence, and trauma. And within this sort of context, for several decades, we've been trying to strengthen our health system and transform it as we move towards universal health coverage. So globally, we know that there is a lot of evidence out there that shows that community health workers can actually improve and assist with health system performance. But there isn't a lot of evidence on large-scale community health worker programs, especially in the African continent and especially in urban settings. So that's the context in which I'm sort of sharing my findings. So more than a decade ago, there was an effort to sort of strengthen our health system through revitalizing and reviewing our primary healthcare system. And there was a primary healthcare reengineering strategy that was introduced around 2010, 2011, which looked at three main focus areas. I'm sure all of us have heard about the district clinical specialist teams. We've heard of our school health teams. And the third arm, which was introduced as one of the first components of the primary healthcare reengineering strategy, was the ward-based outreach teams. So these are teams consisting of community health workers, ranging from about 6 to 10 community health workers in each team. And the teams are led by a nurse team leader. So initially, when the program was introduced, the idea was to have a professional nurse as the nurse team leader. But over time, as there were challenges with actually recruiting and retaining professional nurses, the shift was towards having an enrolled nurse as the nurse team leader. And the idea was that each of these community health workers in these teams would look after approximately 250 families or households, obviously depending on the population of a particular community, the density of that area, and the spatial distribution of those families, and so on. But the emphasis was on really promoting health and preventing disease. So over the last several decades in South Africa, I mean, community health workers have been involved in our health system for many years, and their focus initially, was on disease-specific or very selective approaches, primarily around HIV and tuberculosis. But over the years, the role of the community health workers has evolved. And in terms of the primary healthcare reengineering strategy, the idea was that the community health workers in these teams would provide a much more comprehensive range of services across several health conditions. So this is just a summary of some of the activities that they are meant to sort of address. And what you can see here is that it's sort of aligned to the quadruple burden of disease that we have in South Africa. So the aim is to promote health and prevent disease through providing health education and information in all of these areas. The idea is that they would go into households and communities and screen for various health conditions. And through the screening activities, they would identify problems early and then refer those cases or clients to the next level, which is usually the primary healthcare clinic. They would also be involved in defaulter tracing, both for all the conditions, whether it's mother and child health related defaulters, or HIV and TB, or even chronic diseases, and so on. In addition to the health-related activities, the community health worker teams are also providing psychosocial support in terms of birth certificates, social grants, food parcels, and so on. They would also look at some basic home treatment, like providing vitamin A and deworming doses in terms of ORS, and so on. And also they were involved in community campaigns in all of these areas. So this is basically what the ward-based outreach teams are meant to do in various districts across the country. So in Ekurhuleni, these teams were introduced progressively over a period of about 10-12 years, starting in about 2011-12. And by 2018-19, when these teams were fully established in the district, we had about 178 teams that comprised of about 1,000 community health workers with about 170 nurse team leaders. And they were responsible for about 1 million people in the district. That's about roughly 300,000 households, or roughly about 25% of the district population. So as you can see, it's actually a very large-scale program, and it's been sustained for more than a decade. So it's quite long-term. And as I mentioned, this type of services they offer are quite comprehensive across several health conditions. So the idea was that these community health worker teams, I'll use the term community health worker teams and ward-based outreach teams interchangeably, that they were meant to be almost like the proactive arm of the health system, going out there and actually finding the problems early and bringing them back into the health service. Now, just to share a little bit about Ekurhuleni. Ekurhuleni is an urban health district in Gauteng, the economic hub of the country. The health district has about a population of about 4 million people currently, majority of whom are medically uninsured. And in terms of our burden of disease, it's similar to the rest of the country. But of note was that about almost a decade ago, the Ekurhuleni Health District was flagged nationally as one of 25 health districts in the country that had really bad performance or poor performance in terms of mother and child health indicators. Our maternal mortality was high, our pneumonia incidence under 5, diarrhea incidence under 5, severe acute malnutrition rates, as well as our vitamin A coverage and so on, we were really performing quite badly in that. Our antenatal coverage first visit less than 20 weeks was also quite bad in terms of performance almost a decade ago. So it's in this context that we were introducing these teams in the district. And I've been personally involved in the district in terms of supporting these teams for the past decade or so. So now in terms of our particular study that we did in our district, as we all know, when we introduce public health interventions, in terms of their success or achievements, it's multifactorial. And so it's very difficult to say that a particular intervention alone achieved the desired impact or effect. But we wanted to see whether or not we could show some contribution of the ward-based outreach teams towards improving the performance of some of these key indicators or measures in the Ekurhuleni Health District. So we went through, we actually did a multi-method quasi-experimental study design. We had almost 4 sub-studies in this overall research project. And the way we structured it was that firstly, in the first study objective, we wanted to try and understand what were the outreach teams doing? What were the community health workers doing? Were they actually functioning as intended? Initially, when we introduced these teams more than a decade ago, we were actually measuring their success, almost like their success in terms of the input indicators. How many teams were we establishing? How many community health workers were recruited? How were they trained? And so on. But we were not necessarily collecting process measures or process indicators in terms of the activities that they were doing. So in our district around 2015-16, we decided to sort of start collecting more process indicators. So in terms of determining this first study objective, we actually did an analysis of secondary data that we collected over a 3-year period in terms of those process measures, process indicators. Secondly, we said, if we could show that the community health workers and the teams were actually functioning as intended, if they were supporting their households for a long period of time, could we start seeing the changes in those households supported by the community health workers? And in order to measure this, we did a cross-sectional analytical study where we compared 2 groups of households. The first group, or approximately 400 households, were the intervention households, where the community health workers had supported these households for more than 2 years. And we compared this to a similar number of control households where there was no community health worker support at all. Thirdly, we said, if we have good household coverage in clinic catchment areas, and we were assuming that there would be changes in those households, then could we see an effect on the health indicators at clinic level? And by implication, would there be an effect on the district health system performance in those areas? So for this third study objective, we did a pre and post intervention study. Again, we compared 2 groups of clinics: intervention clinics that had good coverage in their catchment areas with community health worker teams. More than 60% of the catchment area was covered and supported by community health worker teams. And we compared them to control clinics that had a little or no coverage in their catchment areas with community health worker teams. And we identified 9 health indicators that were related to the activities that the community health workers were involved in. And we looked at a pre and post comparison of the performance of those indicators over a 9-year period. So that was the third study objective. And then lastly, we again said, if the teams were effective in the district, what were some of the factors that could have influenced their effectiveness? And we determined this through a cross-sectional descriptive study where we interviewed the teams, the team leaders, and the community health workers. We interviewed health facility staff, and also community members in the households that they were supporting. So that's overall sort of the methodology. So I don't want to go into too much detail there, but I'm happy to share information outside of this meeting on that. So what are some of the findings? And I'm just going to share those very quickly. So in terms of the findings from this first study objective about what they were doing, you can see in my upper left corner, the screening activities that were being conducted by all the teams during this 3-year period that we looked at the process measures or process activities. And you can see that they were screening across a range of conditions. I said that the focus of community health worker programs had shifted away from a disease-specific selective approach to a more comprehensive approach. So you can see here that they were actually doing screening activities across several conditions. I'm just pulling out the child health and maybe maternal indicators and findings for this webinar. In terms of pregnancy screening, if you look at the lower right-hand corner of the screen, One of the indicators that we were really doing badly on in the district was your antenatal care first visit before 20 weeks. And so what the community health workers would do is that they would go into the households with pregnancy test kits. They would identify women of reproductive age, and they would ask them, have you missed a period, or are you having any signs and symptoms of pregnancy? And they would test them for pregnancy. And if they were found to be pregnant, they would then refer them to the clinic for confirmation of their pregnancy and for them to access care. And what we saw over the 3 years was that once they identified the women, most of the women that they referred actually reported to the clinics. And once they reported to the clinics, most of these women were able to start antenatal care much earlier. In terms of child health, there were similar findings in terms of immunization screening as well. The community health workers would go into the households that they were allocated. They would identify children who were under 5. They would ask the caregivers or the parents for their road to health card. They would check their immunization status. And if there were children who were not immunized or who had missed a particular immunization shot, they would then refer them to the clinic. And we would see the same thing in terms of the what the clients would do. As community health workers were referring, most of those clients were actually reporting to the clinics. And of those clients who reported to the clinic, most of them were being linked to care. In addition to screening for immunization, the clinics themselves would also identify children who were supposed to come back for their immunization shots, so almost like defaulters for immunization. And they would give those lists of defaulters to the community health workers, and there too the community health workers would go out to trace those children. And they were successfully able to trace most of the defaulters in terms of immunization, and again get them back into the health system and getting them back into care. So the community health workers played a big role in communicating quite effectively of the need to access certain services such as immunization or pregnancy care and so on. And what we saw was that there was an improvement in terms of health-seeking behavior, because the clients were actually reporting to the clinics. And once they got to the clinics, they were actually being linked to care. So there was improvements in terms of access to care as well, based on this secondary data. In addition to immunization, the community health workers would also look for malnourished children in the households. They were given those MWAC tapes, the mid-upper arm circumference tapes, and they were trained to actually use that to identify children who were possibly malnourished in the households. So they did a lot of screening in the households for malnourished children, and they were identifying a lot of those children. But over time, we noticed that there was a drop in the number of children, malnourished children they were identifying. And when we spoke to the teams, there was a real drop. And the assumption was that in the households that they were supporting, they were finding fewer children, because by now they were educating the caregivers and the parents in terms of what to do with regards to nutrition and so on. So in terms of our first study objective, we were therefore able to show that the community health workers were largely doing what they should be doing in terms of our health outputs. I mentioned that they were also providing psychosocial support. So that wasn't necessarily the focus of our study, but I thought it's important to share part of that as well. They were able to provide birth certificates to children who didn't have, birth certificates, provide access to identity documents. Where they found people who didn't have these documents, they would refer them to the relevant community structures such as Home Affairs. They would refer them to social workers. They would help them to access social grants such as childcare grants, disability grants, old age pension grants, where they identified really poverty-stricken households. They would deliver food parcels to those households. They often identified abused children or abandoned children, and they would refer them to the social workers and so on. So to a large extent, they were able to sort of contribute as much as they could at their level to addressing some of the social determinants of health in the community that they were serving. So for us, this was really important, because it was showing us that the community health workers in our district were largely doing what they should have been doing. Now, in terms of the second study objective, I mentioned that we were looking at changes at household level with regards to some health and social outputs. And we compared 2 groups of households. Now, both these groups of households, your intervention households that were supported by community health workers and your control households that were not supported by community health workers, were largely similar in the sense that they were both economically vulnerable households. We also found that both these households had similar levels of health awareness and knowledge, high levels of health knowledge and awareness, but that in itself was not sufficient to change behavior in the control households. What we saw was that if you were an intervention household, you were more likely to get social support in the form of a social grant. You were more likely to have a birth certificate or an identity document if you were an intervention household. In terms of health-seeking behavior, we found that an intervention household was more likely, the members were more likely to go to the clinic when they were sick, and they were more likely to improve, to demonstrate improved access to healthcare over the past 12 months. In terms of your health outputs, a child from an intervention household supported by a community health worker was more than 4 times likely to be immunized compared to a child in a control household. And in terms of pregnancy, a pregnant woman in an intervention household was more than twice as likely to access early antenatal care less than 20 weeks compared to a pregnant woman in a control household. So you can see that at household level, we were also seeing changes where the community health workers are supporting these households for a long period of time. So that was another important, these are also important findings for us. Third study objective, we looked at proxy indicators that were reflective of the sort of activities that the community health workers were involved in. We looked at 9 indicators comparing your intervention clinics that had good coverage of community health worker teams in their population compared to control clinics that didn't have, that had little or no community health worker coverage in their population. And what we found was that of the 9 indicators, intervention clinics improved proportionately more than control clinics in 7 of the 9 indicators. And out of those 7 indicators, you can see 4 of them are related to child health indicators. So we saw a decrease in pneumonia incidence under 5, decrease in diarrheal incidence below 5, severe acute malnutrition rates were decreasing, and vitamin A coverage was improving in those intervention clinics that had good coverage with community health workers. I was just mentioned that during this period of the study, this was roughly around 18-19 when we were collecting this data, overall the district was improving in these indicators, but we saw more change happening in intervention clinics compared to control clinics. But in terms of severe acute malnutrition, the rate actually halved by 2018-19, at the time when we had the most number of community health worker teams in our district. So for us, this was really important because we were showing that the community health worker teams were really contributing towards improved district health system performance as well. So I just wanted to share some quotes or perceptions from the households as we interviewed them to find out, what were their experiences and where did they see the change in their households. And you can see that the community members in the households are really very satisfied with the services they were getting from their community health workers. They really appreciated the fact that the community health workers are always available for them, that they were providing the right information, that they were communicating well with them. They were assisting them with food parcels and other needs when they needed them. They were checking for immunization status for their children and so on. I tried to pull out the quotes that were specific to child health activities. So overall, with these first 3 studies, we were able to show that the community health workers were doing what they should be doing in the district, and they were effective. So lastly, we wanted to look at, what were some of the factors that were probably influencing their effectiveness. And we found that, overall, the health system support was a fundamental area in terms of the fact that the community health worker teams were really appreciated and recognized. The clinic staff really saw the change that was happening in their health indicators, and so they could see that there was a contribution from the community health worker teams. The teams themselves, in terms of their personal traits, the community health workers, the fact that they were honest, they were dedicated, they were approachable, was really important in terms of how they performed. Their knowledge, their skills, and the ability to do basic tasks and basic things was really important. The team leaders played a big role in terms of assisting the community health workers with problem solving at the community level. And overall, both the community and the health facility was seeing the benefits in the households in terms of all what I've just mentioned. And the community itself also, as I said, appreciated and recognized the role of the community health workers. So overall, what we were able to find with our study was that, the program in Ekurhuleni, which, as I said before, was large scale, long term, and looking at activities over several health conditions, was effective. And we do feel that they are definitely contributing towards improvements in terms of the district health system performance in Ekurhuleni, and can contribute towards us achieving universal health coverage in South Africa. As I said before, it's to understand the potential that they can have for us in terms of this. In terms of our recommendations, I think obviously, as I mentioned before, they're currently just covering about 25%, less than 25% of the population in Ekurhuleni. But I feel overall, we really have to think about how we're going to accelerate their expansion and scale up the activities of the ward-based outreach teams across all our vulnerable areas in South Africa. And we need to really think about how do we formalize and legitimize their role in the health system. Globally, there's a lot of emphasis on community health worker programs. It was mentioned at the World Health Human Resource for Health conference early this year in Geneva. It's also been mentioned, I think, at the African continent level in terms of us supporting community health worker teams across the continent. Nationally, I think in our National Human Resource for Health strategy, it's mentioned as well that we need to really think about leveraging on community health worker teams. The new strategy on our district health system is also talking about how we should strengthen community health worker teams. So there's a lot of recognition that we need to, towards these teams, that we need to think about how we formalize their role in the health system. I think Gauteng took a step forward in the right direction by employing community health workers formally as employees in the health system, but that's not the same across the country. And I think those are the discussions and deliberations that we need to have. Thirdly, we need to see how we integrate them into our primary healthcare services. I think in Gauteng and in several other districts, but not necessarily across the whole country, the role of that nurse team leader as a conduit, as a link between the health facility and the community health workers in the community is a very important role that enables us to to legitimize their role within the primary healthcare services and integrate the role of community health workers in the primary healthcare services. And overall, I think that nurse team leader really plays a big role in terms of us making sure that we improve the management and supervision of the community health worker teams. In Gauteng and in Ekurhuleni, we have another model in terms of supervision. I'm not going to elaborate on that here now, but that also assists us in terms of how we make sure that they are supported, their working conditions are suitable, and we also need to look at how we're collecting data and so on. Lastly, I think one of the things that we don't do enough of in the country is really look at evaluation research or effectiveness research. And I think using this form of this sort of research, we need to do more of it around the country, but using this sort of research to generate local evidence that can actually inform our practice at the front line is really very fundamental and important, and is also important for us in terms of advocacy for change. Yeah, so I think that's my last slide. And I just would like to take this opportunity to thank everyone who's contributed to the study, especially my two supervisors, Professor Eric Book. I think he's on the call. He's been really fundamental in supporting me in getting this study through this, in getting the study completed. And Dr. Jürgen Pille, who used to be at the National Department of Health as well, for their support. And of course, all the teams in Ekurhuleni and the district officials that supported this program. We've got 2 publications out on the study. I've cited them here, and we're hoping to have a few more going forward. Yep, so thank you very much. Back to you, Denise.
Thank you so much. Thanks. I think I'm going to hand over to Nozipho. Nozipho, you're going to ask 2 questions now quickly while Tanya loads her slides.
All right, thank you, Denise.
Yeah.
So we have 2 questions, one from Jenny de Wet. I think, Jenny, you can ask a question. Jenny? Okay, I'm just going to, there's another question in the Q&A. It's from someone who's asking which categories of healthcare workers made up the outreach teams? Did it include rehab therapists like your physios, OTs?
Thank you for that question. I mentioned that the teams were comprised of community health workers and a nurse team leader. So that's what they comprised of. Initially, I think there was, the plan was to have several other health cadres being part of the team, but it was just not possible to get that many resources at that level. So we ended up just focusing on a nurse team leader who was an enrolled nurse, and 6 to 10 community health workers in the team. But they were supported by these additional cadres at either a facility level or a sub-district level, not necessarily at a team level. Thank you.
Thank you. I think those are the questions we have for now. We can move on.
Okay, thank you. I will try and give some time for questions at the end of this presentation. So I've been asked to talk about the role of ward-based outreach teams in preventing child deaths in South Africa and how we can advocate for a scale-up of the program. So let's look at where we are in terms of progress in our under 5 mortality rate. Well, we're aiming to reach the SDG target of an under 5 mortality rate of less than 25. And currently South Africa is sitting at 33, which makes it unlikely that we're going to reach this target by 2030. The leading causes of death are and remain largely preventable in children with lower respiratory tract infection at 19%, diarrhea at 15%, and amongst neonates, prematurity being the most prominent cause of death in neonates, also with preventable interventions related. So we know that we need to look beyond the health sector if we're going to be making improvements and in reaching targets that we have signed up to for child health and well-being. And a major reason for the slow progress in South Africa and in other countries is because our focus has very much been on clinical care and care within frontline health facilities. And we cannot reach the targets, in particular improving child health, well-being and nutrition, without looking at the social determinants that are driving the high under 5 mortality rate. So we need to be looking at social determinants like housing and sanitation, access to clean water, adequate nutrition. And unless we address these determinants, we're in a cycle of treating children and then sending them back to the environment that is in which they're unable to thrive and grow. We have strong evidence to show that investments made at a community level will save more lives than investing at primary care and hospital level, the same package of interventions. And so we need to look at how these interventions can be effectively scaled up at community level in order to try and avert as many deaths as possible. So in terms of our health system, ideally what we want is for most children to be screened at a community level by a community health worker, and for issues that cannot be managed at that level, for referral to be made to first level or hospital level as required. So in terms of our health system, this means that the foundation of our health system needs to be strong community-based systems that can provide care to individuals and households, but also promote action across sectors. And of course, we need to have strong referral mechanisms between these different levels of care. What is happening currently is that the focus is on the first, second, and tertiary level of care. And actually, we're failing in the foundation of our health system, which is at the community level. So what role can ward-based outreach teams play in preventing child deaths? Well, firstly, we know that at least half of child deaths in South Africa actually occur outside of health facilities in both urban and rural areas. Research at WITS has documented deaths amongst children under 5 at 2 demographic health surveillance sites and found that half of children in these sites were dying at home. But importantly, that by far the majority of these children had actually sought care at a health facility prior to their death. And so the linkages between facilities and communities were absent, and the continuity of care was simply not there to identify children whose illness was deteriorating in the home setting. And it's not just in these rural demographic surveillance sites. This is data from Metro East in the Western Cape, again showing that 90% of the deaths due to lower respiratory tract infections are amongst children at home and not within a hospital setting. So we know that access to health facilities remains a major problem in South Africa, and currently 1 in 5 children is living more than 30 minutes from their closest health facility, and the situation is dire for those in the poorest households, where almost a third of quintile 1 households are traveling more than 30 minutes to reach their closest health facility. In terms of the evidence base for investing in community health, we know that community health workers are really the entry point for achieving universal health care. Modeling has shown that 2.5 million maternal and child deaths can be averted if we invest fully in effective community health systems. We know that there's a high return on investment. For every $1 invested in community health systems, there's approximately a $10 economic gain due to the increased productivity from healthy individuals in the population. We also know that it's cost effective, with approximately $5 to $25 per DALI saved through community-based interventions, and this is comparable to extremely highly cost-effective intervention like childhood immunization. Globally, most community health workers are women, and so investing in community health workers would, in Africa alone, provide employment to roughly 2 million women, which would then represent the largest formal jobs program on the continent. And we know that there are proven results in terms of declining under 5 mortality, and we have good evidence from Ethiopia, where 75% of the decline in child and maternal mortality was attributed to the scale-up of the health extension worker program. And in Rwanda, the fastest annual reduction in child mortality at 5% reduction per year has been attributed to their community health worker program. So in South Africa, there's a large role that community health workers can play in terms of the connection between households and health facilities. Currently, the death rate of children who are admitted to hospital in South Africa is sitting at 5%, but this is as high as 8% in Mpumalanga of children admitted to hospital who die in hospital. And in some provinces, this rate is increasing. And this is really a reflection of how severely ill children are when they're being admitted to hospital, and the failure to identify illness and deterioration in the home setting and to encourage prompt care seeking. Another example of our immunization coverage, which between our different vaccines is sitting at between 60 and 90%, an average for the country at 83%. So in terms of global targets, we only have 1 province that is reaching the global target of 95% coverage for children under the age of 1. This is obviously a hugely impactful intervention that community health workers can play a huge role in identifying children who have missed immunizations. If we look across the range of interventions, there's a major deficits in terms of care seeking, in terms of nutrition. Only a quarter of children under 2 receiving an acceptable diet, high levels of poverty and low access to basic services. All of these interventions impact the incidence of pneumonia and pneumonia deaths, the leading cause of death in children, and they can all be actioned within households and at the community level. I'd like to just give some examples of countries that have successfully scaled up national community health worker programs. And firstly, Brazil, where there were major health reforms that led to the creation of the Family Health Program. And this is the program on which South Africa's ward-based outreach team is based. So also teams of 6 to 8 community health workers supervised by a nurse. But in addition to the Family Health Program, Brazil also introduced a conditional cash transfer program called Bolsa Familia. And this is conditional on behaviors including immunization coverage and school attendance. And it has been shown to be a key poverty reduction instrument for the country. So Brazil, similar to South Africa, has extremely high inequity within the country. And through this family health program, they managed to reduce under 5 mortality, including in the poorest Northeast region, to levels similar to the wealthier regions of the country. They found that coverage of the family health program was important in the poorest municipalities. So in quintile 1 municipalities, over 80% coverage of the family health program led to the greatest reductions in under 5 mortality. They had similar reductions in stunting, again, looking at the poorest families managing to achieve rates of stunting similar to the wealthiest families in the country. So Brazil, through this program, has managed to reduce their under 5 mortality rate to 14, so already exceeding their SDG target. And just to look at a few other examples, here we have South Africa in the top left at 33, Bangladesh, a lower middle income country, extremely poor setting, 27, and Nepal, which has had enormous both environmental and climate-related challenges affecting obviously the health of the population, has also managed to achieve an under 5 mortality rate of 27. Both of these countries will reach their SDG target, and they have both scaled up community health worker programs, including allowing community health workers to treat pneumonia at household level. We have an important policy window through the release of the first WHO guidance on health policy and systems support to optimize community health worker programs. And World Health Assembly resolution in 2019, which recognizes the contribution made by community health workers in achieving universal health coverage, responding to health emergencies, and promoting healthy populations. And so the World Health Assembly urges countries to use the WHO guidance and to allocate adequate resources to programs. So as Prof. Thomas has said, one of the major weaknesses is the system supports. And so just as we need adequate system support for formal fixed health facilities, we need the same kinds of support for community health workers in terms of financing, governance, supervision, training, remuneration, and performance assessment. I want to just end by raising some tensions that have been confronting large-scale programs, including South Africa, and things that we really need to address head on if we're going to be able to scale up this program to reach effectiveness. The first one is this challenge and debate, which was raised 40 years ago by David Werner, where he posed the question, is the community health worker a lackey or a liberator? And he was really pointing to the distinction between their role as health extension agents or agents for social change. And most programs that are national programs focus actually on the more narrow service delivery role through things like task shifting, tasks being added to community health workers, their scope of work has become enormous. And so the service delivery aspects get crowd out the more social change, promotion, preventive focus of their work. And although there remains an expectation that community health workers should be involved in health education and health promotion, it's often the areas that are least covered in their day-to-day work. And often the areas that are least valued by both communities and the health system, because communities actually expect drugs and supplies and mosquito nets and receiving actual services, and perhaps the more socio-behavioral aspects of their work are not understood or valued by communities. So in South Africa, our current scope of work for community health workers is enormous, and it does cover all the priority conditions. And so what we see in practice is that certain activities have to be prioritized. And this work by my colleagues at the MRC looked at the activities of community health workers in Sedibeng and Umzinyathi, and found that TB visits were more frequent in rural areas compared to peri-urban areas. Visits for chronic diseases were more frequent in peri-urban areas. But what was important was that there were very, very few visits to mothers and children in both areas, because these other more pressing concerns of getting medication to families really crowded out the more preventive and promotive role with women and children. The second issue is around lay or professional, and most programs fall somewhere on the continuum, although there has been more of an evolution globally towards higher educational entry requirements, longer pre-service training, and a more professionalized role. We know that volunteerism has huge implications because community health workers are largely drawn from poor rural women with low education levels, and there are enormous opportunity costs for volunteerism in terms of their ability to engage in income generation activities for their own families. And so there really are important implications to consider if there's a thought of relying on volunteers. Of course, in South Africa, we have been employing our community health workers, but their salaries have largely been irregular, with poor job security, especially where they have been contracted directly to districts. An investment case by my colleagues at the MRC showed that we need more community health workers for the country, approximately 40,000 more, but that this cost would be justified because we're employing poor women from vulnerable families. They would then in turn be able to spend this salary or stipend on their own families and their own children, and that actually this would be an added benefit for our GDP, the cost of investing in community health workers. As Prof. Thomas said, we have different models around the country. In Gauteng, community health workers are employed by districts. In other provinces, such as the Western Cape, they're largely employed by NGOs. And this does bring with it advantages and challenges, particularly in terms of who community health workers see their primary affiliation to. And this research by my colleagues at UWC, Professor Helen Schneider, has shown the disconnect that community health workers feel to their primary health facility that they are linked with. And in fact, she found that very few community health workers identified staff within the clinic as being involved in any line functioning, supervision or feedback. And so this highlights the disconnect that we're seeing in many provinces between community health workers and the frontline health facilities that they are supposed to be having good communication and good referral networks with. There's also a challenge around whether programs should be standardized or tailored to a specific context. And obviously we have great diversity in contexts across the country, rural areas, and densely populated urban centers. And so we need to think about what's the most appropriate model of care. In areas in Gauteng, they've invested in health posts where there's a fixed structure that community members can attend to consult with their community health worker. But this might not be the best approach in deep rural areas. Another issue to consider is whether community health workers should be more horizontal or more vertical in terms of, do they provide a comprehensive set of services, like, for example, in Ethiopia, or are they specifically focused on HIV or TB, as we've seen in a number of programs funded specifically by PEPFAR, the Global Fund? And this decision has implications for ratios. So a comprehensive program really has to have a very high community health worker to population ratio. Just looking at some global examples, Brazil has 1 community health worker to 750 people, Rwanda 1 community health worker to 260 people. And here in South Africa, we have 5 times the population of Rwanda, but a similar number of community health workers. Our policy framework recommends 1 community health worker to 1,000 individuals. So obviously, we're going to struggle to reach optimal effectiveness if we have such a low ratio of community health workers to the population that they're serving. So what is our role as advocates? Well, many of us are involved in teaching and learning, and we really have got to increase the exposure of our students to primary healthcare facilities and community resources. We need to raise awareness amongst our students and our colleagues about the role of community health workers and enable opportunities for students to really experience their work within communities. And we have got to make sure that we are teaching on the social determinants of health, particularly at an undergraduate level. In terms of clinical services, where community resources exist, we should be having routine referral of children and families on discharge from hospital to ensure continuity of care. And we need to advocate for community health workers as a valuable resource in our health system, and to advocate for more of them and that they are paid a decent wage. So reaching the SDG targets for child health and nutrition won't be possible in South Africa unless we extend access to care at the household and community level through trained community health workers. But this is only achievable with political commitment and financing. And we need to make sure that community health workers really become the foundation of strengthening our health system and a priority for health sector funding. Thank you.
Thank you so much. Thanks to both our excellent speakers and for this wonderful session. Unfortunately, we've run out of time, but I think that we heard from both speakers today how we can advocate for adequate support for CHWs. And I think whether that is teaching or training or gathering evidence that can inform these changes. And so with that, I'd like to again thank both our speakers. And just a reminder that the recording will be available on the website. And then please do diarize the next date of the next webinar will be on the 26th of October. So please look out for that and register to join the next webinar. And with that, we'll close today's webinar. Thank you to everybody for joining us and for your attention. Take care. Oh, sorry. Prof. Lena, did you want to answer a question quickly?
Thank you. Yes, I think there were a couple of questions that were in the chat. Do we still have some time? One of the questions was around whether or not we can what is my opinion about using enrolled nurses, because I think several provinces are still struggling with that concept of professional nurse versus an enrolled nurse. And I think in our district and in our province in Gauteng, we actually found that we didn't have the supply of professional nurses. And so we actually had to do a skills audit looking at enrolled nurses and their scope of practice. And we found that enrolled nurses were more than capable of fulfilling the role of a nurse team leader. So for the past 10 years in Gauteng, we've been actually using enrolled nurses as the bulk of our nurse team leaders in the province. So that's really worked out well for us in terms of supply and demand. And it's now also part of the national policy on WBPHCOTs, where they're recommending that we use an enrolled nurse instead of a professional nurse. There was another question about whether community health worker teams should be providing vitamin A and vitamin and deworming. And yes, they have been doing that as well in our province and in our district. It's just that for our study, we didn't have data at that point on that, so I couldn't report on it. But they are definitely providing vitamin A and deworming doses in households. I think the last question was around what sort of recommendations would I make to the National Department of Health in terms of sustaining ward-based outreach programs. And I would say that we definitely have to continue with these programs and these initiatives. It's part of national policy. It's in our HR8 strategy. We really need to almost put our money where our mouth is. We know that there is evidence out there showing that they can add value to our health system. I think we have to start saying the foundation of our primary healthcare system is going to be our community health worker program, and our primary healthcare system should be community health worker led. We used to say before, and we still say, that our district health system is nurse based. So let's say our whole primary healthcare system is going to be community health worker based. And I think we need to start bringing out those sort of concepts and themes and working towards that. And also doing research such as this to actually show the evidence in terms of how such programs can work. I think as we go and request for additional resources and funding from National Treasury, if we have this sort of evidence, it can actually certainly add to the business case that we are making. So yeah, we have to sustain them. We have to put our money where our mouth is. And I think Prof. Doherty mentioned it very nicely that investing in community health workers is investing in the health and the economy of the country as well, because you're creating opportunities for decent, safe work for many of the vulnerable in our country. Thank you.
Thank you so much, and thanks for responding to those questions. Prof. Doherty, do you want to? There's a question in the chat that asks how can the model of specific support versus general support be further elaborated and maybe have a blend of such CHW? Would you like to maybe respond to that before we close?
Sure. I think that, the ratio of community health workers to population is absolutely critical in that question. So if you're going to have community health workers that are only focused on TB adherence support, then you don't need to have as many, depending on your TB burden in your sub-district or your district, as you would need if you're going to have the kind of model that we have in our policy framework here, which really requires our community health workers to cover every priority condition. And then you need a really, really fine coverage of households with very few households allocated to each community health worker, because we know the kind of vulnerable households and the many complex challenges that can be found within a single household. I also think from a standpoint of looking, across the determinants of health and illness, focusing just on one aspect, for example, TB and HIV, is really not going to be beneficial for the family if they also have an ill child and have a pregnant woman in the household as well that needs care. So I think we need to be looking at comprehensive care to households, but then having really small number of households allocated to each community health worker to achieve that.
Perfect, thank you. I did see, I think that Jenny has been added. I'm not sure, Jenny, if you still have a question, if you'd like to unmute.
No, thank you. I'm fine.
All right, perfect. Okay, I think we'll close there. Thank you everyone for staying a few minutes longer. And again, thanks for your participation. We'll close the webinar now. Take care.
Thank you, Tanya. Bye.
Cheers, Nazipa. Well done. We'll send you the recording.
All right. Thank you so much. Bye.